Well, good morning, everyone. My name is Larry Boris. I'm with the National Association of Worksite Health Centers. Pleased to have you join us today for our monthly program. This topic for today is planning your first worksite health center, as well as the value of accreditation. We're pleased to have two of my favorite speakers participating today, David Kite from Mercer and Dr. Accreditation Association of Ambulatory Healthcare. What we want to do today is to really give you a foundation of knowledge on what to do, not only for a first center, but also if you are creating a new center or transitioning even perhaps to a new vendor. This will give you a good idea of the kind of things you should be looking for and the kind of things you should be planning for. Every employer is different, every center is different. But I think what you'll find is that you'll gain a lot of value from the variety of things you may or may not have thought about. And then we'll be talking about the real value of considering having your center accredited by AAAHC, the value of accreditation, the process, how it can add to the quality and operations excellence of the organization. This program, of course, is run and developed by the National Association of Worksite Health Centers. NAWHC.org is our website. We're a national organization of over 100 companies, primarily employers, unions, and others who sponsor on-site, near-site, mobile, and virtual health centers. We provide assistance and direction, and staff support, resources, benchmarking surveys, networking, and of course, educational programs like this to help people develop and expand and understand the nuances of worksite health centers. We don't sell or endorse anything. We are a clearinghouse of information. And I would encourage you to consider being part of the organization if you're not done so. So please visit this website or contact me. And please consider being part in person at our 10th annual forum, which will be the celebration of our founding back in 2012. It'll be in Nashville this year. And again, all a day and a half program on creating and expanding worksite health centers. So we'll hope you'll participate in that. Our next program coming up later this month is on creating hospital managed worksite health centers for employees of hospitals and area businesses. So if you're a healthcare system or a hospital, we encourage you to participate or learn about that. Then in April, we'll have a program on behavioral health services and innovations. And as I said, our annual forum coming up. So at this point, let me turn it over to our first speaker, David Kite, to introduce himself and have the program. David, over to you.
Thanks, Larry. Thanks to NAWHC for having me. As Larry mentioned, I'm with Mercer. I lead our worksite clinic consulting practice and have been operating in this space for coming up on 15 years. Today, if you go to the next slide, been asked to talk about planning a health center, whether it be your first or adding another one to your enterprise. I'm going to focus most of my time talking about process and key decisions to consider as you build the business case and plan for your health center. And I think this dovetails nicely with what Dennis will talk about, meaning, depending on the model you pick, how do you really know that your services and program are being delivered based on best practices? And that's, a key piece of where AAAHC comes in. So next slide. So just kind of setting a foundation, where do we start? Typically, we start by building a business case, which is really just a justification for making this investment. And it is a big one. And it's one that's tends to be sticky and will be around for a long time. So we want to do it right. The core element of every business case is a feasibility study. And by that, I mean projecting costs and associating the value on investment with the clinic. But it's really not that simple. As Larry alluded to, all health centers are different, different services, different staffing models, different plan designs. And it really starts by understanding the problem that you're trying to solve for, i.e., what are your goals and objectives? What are your cost drivers? Then you really want to, after you've kind of spent time there and understanding what you're trying to do, then it's really focusing on defining what we call a conceptual framework for your health center. Who will be eligible? what services are going to be offered, how it will be staffed, and I'll go into more detail in a couple of slides, plus a number of other questions. And then after you've spent time there kind of developing your strategy, then you're really ready to build that feasibility model. Take the baseline data for your population, understand the demographics, the baseline health status of that group, identify what specific cost drivers you're dealing with, understand the healthcare ecosystem that the clinic will be a part of. That really kind of sets the foundation for looking at essentially how many people are going to use it, what you're basing your eligibility choices, and then you'll have the data to really project what your visit volume will be for each specific service line that you choose. And having all those pieces in place will allow you to project forward what your operational costs will be for this health center. And then kind of probably the most important piece to add on is, what do you think that value on investment will be? And part of that is a discussion about methodology. At its core, it's medical and pharmacy claim savings, impacting total cost of care typically, but there's many other components that you'll need to decide, does it make sense to have this be included in our kind of savings story? And while the feasibility model might answer your costs and ROI questions, what does you really, I think, look at other things like access to care in a specific geography. Are you dealing with a shortage of providers? Does your office or plant that you're trying to serve have sufficient space for this project? Where should it be? What's going to lead to the best outcomes? And also kind of thinking about it from a cultural perspective, making sure that this is something that will be embraced from top to bottom. Are managers going to be supportive of this? Do you have C-suite support? Is the employee culture going to support this, or do they have privacy and confidentiality concerns? So there's a lot of different questions to ask, but I think it starts with this kind of framework. If you go to the next slide. So, as I mentioned, you really want to start by trying to figure out what problem that you're trying to solve. This data comes from our 2020 national survey that we did with NAWAC. And as you see, the number one objective listed was access. Why is that so important? Is that important to you? It's typically number one, because I think there's a growing recognition that regular access to a primary care provider is associated with positive outcomes, higher rates of preventive care, lower rates of preventable ER, hospital admissions, specialist utilization. There's a lot of different research that supports that focus. And as we know, there's been a growing shortage of primary care providers, and that's projected to continue going into the next 10 years. So I think those things are driving access to the top of the list, but there's a lot of different things that and reasons why you would want to implement a health center. Not to mention competitive reasons. In certain regions, offering this benefit has become a competitive requirement. So the key to starting the design process is really to identify this problem that you're trying to solve, so you can ask yourself key questions. What is driving our medical cost trend? What are the healthcare needs of the business? We really can't solve the problem unless we know what it is. If you go to the next slide. So to dig a little deeper into the conceptual framework that I mentioned, key strategic decisions to be made, and a little bit of a kind of cascade effect, and you really have to work through them sequentially. And there's a lot of other questions on top of this, but at its core, you really need to start here. Eligibility, is this just for enrolled employees or everybody? Contractors, members on COBRA, retirees? These are questions that you have to ask and answer. Services, how does that fit your objectives? What services are needed to most effectively address the problems, i.e. cost drivers or other? What does utilization look like today? If you're reconfiguring your health center, what is utilization? Is it what you would expect? Are you trying to increase it? then that leads into staffing decisions. Do you have a preference for a physician or a mid-level? Are you trying to create a care team? What roles are optimal based on the size of your population? Do you need an RN care coordinator? Do you need a behavioral health resource as part of the on-site team? Plan design, a growing category. It's always been important. There's a renewed focus on it with the new programs that have been launched in the last couple of years. But you really have to understand how plan design drives towards your objectives. Is removing copays as an incentive? If you go back a slide, yeah. Is removing copays, sufficient to drive the utilization that you want? You want more of a stick approach with, plan design choice options or financial incentives that drive to the provider level. These are design elements that you need to make upfront because it has an impact on the overall cost of the program. And then, the facility is a key piece. It ties directly to access and convenience based on its location. The design aesthetic is critical to drive foot traffic and engagement. And you have to think through barriers, and it really starts by assessing the facility and knowing what space might be available, mapping out pros and cons of each individual location, as well as engaging a contractor as part of the process to get an accurate assessment of what the cost of building a facility will be. And that can vary based on geography. And then, culture, again, I think it's a really critical piece to think about. Of how managers will support this, because that really will impact utilization throughout the day in a health center, which impacts ROI and feasibility. So these are really just a sample of decisions that you need to work through before moving forward with any feasibility model and as part of the kind of bigger business case. Go to the next slide. This is my last slide, but important in that depending on the needs of the organization, business case studies, feasibility models can go a lot deeper. Where I'm kind of talking about like kind of the core that I'd recommend, and then the other elements that you choose to include as part of the process is really up to the needs of the organization. It's really common to do geo-access analyses, mapping out where people and dependents live in proximity to potential health center locations. Sometimes this is done in partnership with a potential vendor partner. I'd recommend typically that it would be done prior to that conversation to really inform decision making around what expected utilization levels will be, including mapping out drive times, because proximity and convenience really drive engagement levels. As well as, is it common to dive into deeper levels of data depending on its availability? Social determinants of health has been embraced in the last 3 to 5 years. Often that data may not be available, but it can provide really helpful information of understanding what the barriers to getting to care are. Issues like transportation or finances really can be important to navigate around, which lead to levels of utilization as well as financial outcomes. So really important to kind of think through what level of depth is going to be sufficient to meet the needs of a C-suite or stakeholders that might be approving this type of an investment. And it's also really valuable to do additional planning in the areas of employee focus groups or direct stakeholder interviews. For larger employers, they may be dealing with different facilities and planning from corporate for a regional location, and without full knowledge of the on-the-ground staff and their support of this initiative. So important to engage facilities managers, local HR professionals, people that will know the culture in that location, to give really valuable information, including, thinking about beyond just the demographics of the eligible population, but do they have a preference for hours of operation or the type of provider that they want to be staffed at the clinic? So a lot of valuable information can come from that, but it requires additional work and cost. In addition, beyond all of that, there's other kind of housekeeping things that you need to do related to compliance, of making sure that your choices throughout the process are consistent with state, federal regulations, not to mention IRS and high deductible plans as being a common and more difficult one to deal with. So just want to be really thoughtful. And then the last piece that I'll focus on is having a measurement plan in place. In 5 years, how are you going to look back on this and know it was successful? So having that structure, what the key metrics that you're going to focus on and track short, medium, and long term is critical to be part of the overall plan. So hopefully that is helpful in framing out, the approach for planning either your first or new health center. And I'm happy to answer questions at the end of the presentation. So now I'll pass it over to Dr. Dennis Schultz.
Yeah, we'll be taking questions from everyone before, at the end. So please make sure you put your questions into the chat box. Otherwise, I will call people at the end of the day for any questions that you have. One thing, though, I would ask David, if you put on the side that you'll answer later, engagement is such a critical aspect. You talk about a communications plan, but you don't list out any specific incentive plan. And if you'll talk about that perhaps a little bit later, how you get people to actually use the center as well as communicate that it's there. At this point, let's turn it over to Dr. Schultz. Dennis, to you.
Thank you so much. I'm Dennis Schultz. I'm a physician with the Ascension Medical Group in southeastern Wisconsin, the Milwaukee area. And it's a pleasure to be here to talk about two favorite topics, which is accreditation and on-site clinics. I've been involved with accreditation for at least 25 years, many of those as a board member, but also committee member and task force member. And I continue to be involved in the primary care task force, or the primary care standards group, as well as a surveyor. On the other side, employee-based clinics, I've been involved with them. My background is occupational medicine as well as family medicine. I trained in both. And I was in on-sites for occupational health during my residency. The past 20 years has been more involved in on-sites for primary care. And beyond that, I've gotten my healthcare, my family's healthcare at a comprehensive clinics, company-sponsored clinic for 18 years. Total, and I can tell you, and they were accredited under HHC, I can tell you that done properly, you really cannot get better care than what you see in employer-sponsored clinics, just because of the kinds of things you can do in that environment compared to the usual fee-for-service environment. So, next slide. Oh, next slide. So the slides that we've got, well, before I start, let me piggyback on what David said. What the planning stages where you're trying to figure out what do we want to provide, who do we want to provide it to, what are our primary goals, what are our outcome measurements, those elements that were listed on those slides are critical to the successful performance and how you do an accreditation as well. When I have run into issues with different clinics, many times it's because the initial expectations for that clinic change. And it may be that the transition from urgent care, for example, or convenience care to family medicine sounds like it would be easy, but sometimes it's just not. So the more you can clarify up front what you really want and what success looks like, the more successful you'll be and the easier the accreditation process is. Because the accreditation process there are a whole bunch of standards, and in the slides that I've got, we'll be going over what the standards are, what the process is, a little bit about the background. But with the standards, you're judging against these external standards from an accreditation group like HHC, but you're also, as a surveyor, looking at the internal standards and the guidelines and the policies and procedures and the goals of the organization you're surveying, and you're trying to assess how they're doing on that as well. And the more aligned everything is as one goes from the planning stage to the implementation stage, the easier this whole process becomes. So take those slides that you've already seen to heart, use them, and it'll make the whole process easier and much more likely for success. Anyway, next slide. So AAAHC, a little bit about the background. It's been around for over 40 years. It started off with a series of professional organizations who wanted to create a system that acknowledges quality and promotes quality, basically. And what they came up with, these organizations were community health centers, student health centers, group practices, freestanding ambulatory surgical centers, healthcare plans. So organizations that represented these got together and created standards, and then created a process of identifying and training surveyors. And the whole idea with the process is that individuals from one clinic or facility would be evaluating a different, and they would evaluate against the standards, but they would also bring information, consulting information, tips, clues from what they had seen in the past and from their own organization to whichever organization they were surveying. And they would also learn from them and take whatever they found and go back to their own organization, and improve that. So that idea of collaboration and peer review, which was present 40 years ago, is still present in AAAHC. And if you run into old timers like myself, who've been around for quite a while, the reason why we continue to do this despite having a busy practice is because of those characteristics. You have to evaluate the standards, but you're also trying to provide advice and learning yourself something that you can take back to your own organization. Next slide. So quality has been a part of AAAHC from the very beginning. David mentioned a number of things that we would standardly use as outcome measurements that are part of the AAAHC process. AAAHC also has an Institute for Quality Improvement that is involved in research, that develops tools that you use, and sponsors studies which organizations can participate in to do benchmarking. One of the recent emphasis has been the 1099 strong. You see that at one of the points, and you'll see that in the next slide. In fact, next slide, please. Which is a newer initiative, certainly within the past 5 years or so, of trying to find ways of supporting the organization in between the accreditation surveys. Accreditation surveys, when you go through the process, you receive a three-year term of accreditation, and that's 1,095 days. In the past, commonly, there was not a lot of activity that went on between surveys, and AAAHC identified that as a significant issue and started developing programming to bridge one survey to the next. Because quite honestly, if you can take what you had at that first survey and build upon it for the next survey, you're going to be extremely successful. And certainly I've been in situations, all of us surveyors have been on the other side of the table, because we've championed our own organizations through the accreditation process. And we know what it's like to have gone through that, get that big sigh of relief after the surveyors leave and say, well, we're going to take a quick break and catch up on some other things and then get back to this. And 18 months down the road, you realize that you've really let things lapse, and before you can start building up, you need to patch up the things that you've sort of let lapse for the past few months. So acknowledging that, AAAHC has developed a series of programming to support organizations and allow them to build upon their strong foundations, and that's what this program is all about. Next slide. Here are a list of typical activities that can occur, and there's a lot of programming that's done as well during the interval. Certainly, the benchmarking is critically important. Working on areas that were identified as needing some improvement, which would benefit from some improvement. Policy or practices have changed so dramatically. What with COVID and all that's been going on in the last couple of years in healthcare, taking a look at that and making sure that you're updating policies and procedures, consciously deciding what elements are going to be important going forward, and how you can build upon it. And certainly telehealth is an area that has made dramatic changes in the past couple of years, and thinking about how that can be used to serve your patient base. Those are the kinds of things that AAAHC is supporting during the interval between surveys. Next slide, please. So HHC has 6,100 different, they've accredited 6,100 different organizations currently. And here's an example of a number of ones that are involved in employer-sponsored healthcare. You can see they're very, very common names. And if there's any questions about the value of accreditation in the process of putting clinics together and managing them, folks from any of these organizations can tell you how it's helped them. Next slide. This slide highlights the fact that risk management is a very, very important part of the accreditation process. And within the standards, the risk management components are integrated tightly with the quality improvement. And my simplistic view of the whole process is that the quality management, quality improvement sides increases the good stuff that's going on, and the risk management decreases risk and the bad stuff going on. And they have to be tightly bound in order to work effectively. That's part of the accreditation process as well. Next slide. So why pursue accreditations? There are a wide variety of reasons why organizations pursue accreditations, ranging from competitive advantages to efficiencies to quality. In my mind, what accreditation really does is it forces you to focus on what's important throughout. There are so many day-to-day things that can come up when you're administering a clinic or a series of clinics that divert you off what's important, and you think it's just a temporary diversion, but it turns out to be longer than that. With accreditation, you're driven to keep focused on those things that are valuable. These are listing them, but in my mind, that's really the bottom line. Next step. So you've looked at it, you've decided there are a variety of you've decided to proceed. There are a wide variety of accrediting organizations that one can use. How do you start sifting through which one is the right one for you? This lists a variety of particular elements to consider. You can see them, as well as the ones that were listed in the slide before for why you want to pursue accreditation. But in my mind, it really comes down to two things. One, the value of the standards themselves. The standards are really the North Star. They're what you're working towards. And if those standards do not resonate with you and your organization, it just doesn't make sense to pursue them under an accreditation. Go to another accrediting body that has standards that do. And then the second thing is the accreditation process. It's going to be the interactions with the accrediting organization. It's going to be the surveyors coming in and visiting. You're going to be bearing your souls to them and talking about how your organization works, details of what's happened, and credentialing issues and all the rest of that. It's got to be a process that is of value and improves, not only assesses the standards, but also gives you value. To find out about that, the best way is to talk to organizations that have undergone accreditation, see who they've used and what they've learned and what they've done. Next slide, please. So where do you start? You've looked at the standards, although that's part of the first step is actually learning the standards even more. But you've made your decisions. Where do you actually start? And if you look at this list, it's really basic project management steps and tools. The standards, developing your team, figuring out your resources, organizing, the self-assessment, initial self-assessment and ongoing self-assessment. But I think just as important as this question of where do you start is when do you start? Because if you're starting with the planning for your clinic, it's the whole process. It's a different process, and it's a much easier process, and it's one that's going to be much more fulfilling. Your chances of really improving based on the accreditation process increase if you can start it with the planning of the organization itself, the clinic itself, because you can set the stage, you can set timelines for the accreditation process. You can even bring it in during the interview process. And certainly when I was in the process of interviewing folks for on-site clinics, primary care providers, primarily, you set the stage about what you can expect, what's different about this kind of environment, and you can also bring up the expectations for accreditation. Next slide, please. With that, we're transitioning into the standards themselves. I already mentioned how important they are. If you see my picture, this is the standards. This is the book. This is how thick it is. Mine's a little bit worn with a bunch of notes in it. Only about half of this are the standards themselves. They're not that extensive. The rest of it is resources. So it's got all of the worksheets, for example, that we use if we're coming in and doing our clinical record review or credential review or personnel files. All of that's included within this. And it's readable. So you get a set of the standards and take a look. The way they're organized, the first 8 chapters in this book are standards which apply to all organizations because they're central to the process of caring for individuals. They talk about rights and responsibility, governance, administration, quality of care, the quality management and improvement program, as well as risk management, how you manage your records, health information electronically, as well as, well, you don't see paper much anymore, electronically, infection prevention, and then facilities and environment. They're all important to all organizations. Next slide, please. Then you've got the adjunct chapters. Now these only apply if the organization provides the service, with 2 exceptions, and those are highlighted in blue on the slide. So for a primary care organization, anesthesia and surgery applies because you're doing lumps and bumps and minor procedures. Pharmacy for any medications you've got in the facility. Pathology if you use CLIA wave testing, which is quite common. Diagnostic and other imaging, that depends if you've got an ultrasound, if you've got an x-ray. Dental services, if you provide those, and so forth. It includes, there's an occupational health, there's a behavioral health, there's health education and promotion, and then there's medical home. Now, dental services has a dental home subchapter in it, and medical home is a separate chapter. Those are ones that we apply only if an organization asks us to apply them. So they're different than any of the other ones. And the dental home and the medical home both really represent the highest level of care you're going to get in dental and medical services, primary care medical services. Next slide. So next step, getting buy-in from your team. Again, it's a much different animal if you are setting the stage and saying accreditation is just part of how we operate. Then you don't have to get buy-in because the buy-in's already there. You've got to maintain the enthusiasm and maintain the buy-in. But if you've got a clinic that you are going to go through accreditation that hasn't gone through before, this is critically important. Critically important. The communication, the assessments, the planning. Now that get the buy-in from the top down, also critically important. And for me, I want an enthusiastic buy-in. I just don't want a yes, I want excitement. Part of that buy-in is getting your group to figure out how to make the process fun, maybe a little competitive from one clinic to the other or one area to the other, but just have to plan for this and communicate. Next slide. Self-assessment. A couple of slides ago mentioned how self-assessment was important in the initial stages of planning, and it actually is important throughout the whole process. There we go. So now, if you're talking about a startup clinic, the self-assessment looks different than a clinic that's already operational, because the self-assessment for operational clinics, you inevitably, if you're like the clinics I've been involved with, you inevitably are going to find processes that you didn't figure were there, that are a bit surprising, that you do want to change around. And that assessment identifies those at a time before the surveyor is there, when you can improve and you can address issues that you identify. But if it's a startup clinic, the self-assessment really is a monitoring process of whether you're staying on task and whether you're staying on timeline. So very, very different. But with the self-assessment, if you do that properly, the surveyor who's coming in is not going to, you're going to know everything that surveyor is going to tell you might be an issue or be wrong. And actually you will have addressed most of those by the time they arrive. You know, we always say that the accreditation process is an open book test, and it is. The standards are the standards. And what I found personally, with the self-assessment for clinics that have not been part of the accreditation process before, is you really learn more in that process than you do from the surveyor, because you have your own team looking at all these different areas and coming up with issues and concerns and areas where you're really succeeding, where you're going above and beyond. So pluses and minuses, but the self-assessment is critically important. Next slide, please. What is this slide all about? Make it feel like the real deal. This has to do with the mock, what we call a mock survey. As you're planning for accreditation, it's extremely valuable to take some of your folks and send them over and to a seminar that HHC offers called Achieving Accreditation. And what that will do is teach you all about the standards and all about the process and all about what we do as surveyors coming into an organization. Telling the individuals who are attending, you're going to chair the mock survey. So you're going to pretend like you're a surveyor and you're going to take us through the steps. Really incentivizes them to learn more from the Achieving Accreditation program. In fact, if you're teaching at one of these programs, you can tell who is going to have to go back and do a mock survey, because they are the ones with the most insightful questions. Anyway, so the purpose of this mock survey is to do another self-assessment, but it's also to prepare everybody so there are no surprises when the surveyor comes in. You don't want individuals, when they're asked a question, to have that look of a deer in the headlight. And that happens. And it might have happened to us too in earlier days when we were asked the same questions from surveyors. And that can interfere with how much value you actually get out of the survey itself. So going through this process of a mock survey is valuable, but also understand that as surveyors, when we come in, we've seen that same look, we've dealt with that same issue. We understand that it can interfere with the process of getting information or getting value from the survey, and we address that as well. Next slide. A little bit about the resources as well. There's an awful lot out there. I already showed you the book. There's a bunch in there, but there's also a lot with HHC as well, including the roadmap. And the Institute has got a lot of value. I remember that when we were trying to get a program going for weight loss, HHC actually had one of the better charts, resources, worksheet for that. And so we used that at one of the clinics that I was working in at the time. Next slide, please. Next slide. So a little bit about the accreditation process. And you probably have a sense of this from the discussion so far. It really is a discovery process, not just a simple inspection. So it's not a matter of sitting in a room, reading some things, and then going out with a clipboard and checking it off. You really want to find out how the clinic operates. You also want to find out if the clinic is doing what it says they're doing in their policy and procedures, if they're working to the standards of HHC, but also working to those internal standards and those goals that were set when the clinic was started. So going out and talking to individuals, finding out how people are doing who are employees as well as patients is an important part of the process. And as you may have gathered, it's consultative. So it's a give and take. Again, you have to evaluate the standards, but a lot of those standards don't give you an absolute one way to do things, in part because they're written so they can apply to a wide variety of settings. What those standards actually do is they give you goals, goals to work towards. And then you as an organization figure out how you want to do that. So it might say, for example, that for patient safety, you follow a national guideline, or you follow a professional or national guidelines. So it's up to you to decide which guidelines and be able to tell the surveyor when you come, and then we will double check to make sure you're doing that. But that's the collaborative, consultative, as opposed to it has to be done only one way. Next slide. What this slide is a reminder that medical home is a different type of standard. It really draws from a number of other standards. If you've got a medical home, you're trying to focus the entire organization around the needs of the patient with an understanding of what medical best practices are. And so if you decide on medical home, and I would encourage any organization that provides comprehensive primary care to definitely go ahead and ask to be evaluated under the medical home. There's no downside. It won't affect the rating of the rest of the chapters, and it'll give you a good idea of how you stand with the development of a patient-centered medical home. But you have to take a look at all those other chapters and standards and see how it relates, because it all has to be tied around the patient. Next slide. A little bit about the accreditation process. I think the one thing that's important to know is that from the application to the scheduling to the on-site survey, what we are trying to do is make it as convenient as possible for the organization. And part of that process is a complete revamp of the standards. What HHC is trying to do at this point, or what they are doing, is creating a new system of standards where the standard book, where there isn't just one book for everybody, there's actually a personalized book based on the types of services and type of the organization you are. But even without that, we're trying to as a surveyor and as somebody involved with HHC, we're trying to tailor it to the needs of the organization as well. The survey itself gathers information. It's actually HHC that decides upon accreditation. Next slide. A little bit about what happens when we get there. There's an initial orientation conference. There's a facility tour, sort of a meet and greet. Part of that is to set expectations. So before you arrive, there is a call that goes out to the organization, and we try to plan on what the most effective way is of getting our information while minimizing the interference to patient care and the things that have to go on day in and day out. Then we arrive, orientation conference confirming that, a facility tour, and then we start reviewing. You do have to review paperwork. You do have to review policy and procedures. You have to look at clinical records. You have to look at credentialing files, and you have to interview people. But then the fun stuff occurs where you get to go out and see what's actually happening within the facility itself, confirming what you've read and what you've seen, checking out the daily processes. Part of it is also following a patient. If there's a procedure going on, you like to follow a patient through a procedure process. You'd also like to follow, if it's medical home, you do want a medical home patient and follow them. And that process really isn't to judge the care as much as it is to judge the process that the organization has in place to usher the individual in and out, seeing how much of it is patient-centered, who does what on the team. We also like to listen to the huddles that occur in the morning, usually in the morning, it depends, and to try to get a real good idea of what happens there. At the end, there's a summation conference where we talk about each one of the chapters. We have to comment on any of the standards that are rated less than fully compliant. We need to comment on those and discuss those, but we don't say which standard specifically. We don't give out specific results during that summation conference, but we comment in general terms about those standards. Generally speaking, at the summation conference, there are no surprises because it's been an ongoing discussion throughout the entire course of the survey up until that point. And the summation conference is also a time for us to make sure that we've gotten things right. If there's certain information, we've dug deep to try to find the information that relates to the standards, even if the organization wasn't able to provide it right away. If you can find it, it doesn't make any difference, and you do look for that. Anyway, it's a time, if you haven't found the information, it's an opportunity for the organization to tell you so that you're sure that you get your report right as it goes out to HHC. Next slide. And just a reminder that after we submit the report, HHC reviews it, and HHC then provides the decision to the organization. Next slide. And these are the options. They are a 3-year survey, a 3-year with an interim, 3 years with an interim survey. What does that mean? If an organization is providing good care, but there are a couple of significant areas where you feel that improvement needs to occur, then they will get a 3-year term of accreditation, but a survey team will go back in and double check a couple of areas where improvement was needed. And that's the interim survey. It's a very focused survey. It's for organizations that have been accredited, but need additional work in a particular area. In some cases, it's just because they haven't had time to address that area. And they, for whatever reason, need more time. That would be an interim survey. Non-accreditation, I just don't see non-accreditation occur. It's possible. I've run into the situation before, but particularly within the primary care environment, these are not, people who are going through this process are doing it voluntarily, and are prepared. They really do a good job of preparing collectively. So I just don't see non-accreditation. It is possible though. It can happen. Anyway, so how to get more information? Here's how you get more information. I'm not part of HHC staff, but Lee is, and we'll be glad to address any of your concerns. And with that, I'll stop and turn it over to questions.
Thank you very much, Dennis and David. At this time, what we're going to do is take some questions as well as go around the table. So we do have one question that was formally submitted. Dennis, would it make sense to sign up for accreditation when you're first starting out a clinic to help guide the overall operations?
Absolutely, because then you can use those standards. You can interview. You can set the stage. You can set the expectations. You don't have to worry about reworking practices that you don't have to reteach anything. You can teach folks the right way, first time round, and track how they're doing. So it's absolutely a great idea. And I've been in situations where we've started up clinics for organizations that know they want accreditation. It just makes the whole process much, much simpler.
Great, thank you. David, the question I raised earlier with you, talk a little bit about incentives and how to encourage and utilization of the clinic when you're first starting.
Yeah, I think you can point to the survey information to kind of get a feel for how different employers approach it. I think it's approximately half of employers use removal of copays as the incentive to utilization, but that won't really, significantly move the needle. I think, use stronger incentive strategies to really get to, the 60, 70, 80% utilization. There's a growing percentage that use premium reductions tied to selecting the plan, the clinic as a plan, as a really effective way, but it's a very disruptive way. I think probably one of the most common approaches is to use incentives tied to biometric screenings or an annual physical as an entry point into coming to the health center on an annual basis, and really to leverage that opportunity for creating a provider-patient relationship. And I saw your other question about transitioning clinics from OC to non-OC. I think there's a number of different things that you need to consider. We've done it for a number of clients. I think it starts most effectively by doing an audit, an assessment, and it goes beyond kind of the HHC piece, but kind of looking at it more strategically of understanding the starting with staffing. Do they have the capacity, the credentials, the interest in shifting their focus and adding in primary care services? Are you going to need to add staff? Looking at existing equipment, as well as the space. Often space is limited, and adding in primary care needs significant additional space. So that might be a no-go just from the start, as well as the kind of questions around co-location of primary care and occupational health. Often there's privacy, confidentiality issues, and it's best to potentially keep them in separate locations, even though there's benefits to coordination and information sharing. And then I think the standard feasibility model process applies in trying to identify, what the optimal non-occupational model is around all of that.
Okay. Also, got a question, David. Ballpark wise, how much should you plan for a clinic?
How much should you plan?
Plan to budget. I'm sorry, budget for a clinic.
That's really dependent on the population that it serves and the choices that are made. I think from a budget perspective, for populations under 2,000, you're typically talking about a single provider model. And we see, and it depends if you pick a physician or a mid-level, and then other ancillary roles are included. So you're typically starting in a range from $500,000 to $1 million a year. And then as you adding in costs with scale of based on the population that it serves.
Gotcha. All right. So what I'm going to do now is go around the table, and I'm going to call on individuals who have registered and invite them to talk. So let me start out and invite Monique Avia from Stonehill. You have any comments or questions, Monique?
Hi, can you guys hear me okay?
Yeah, just fine.
Oh, thank you. Thank you for calling on me. That's great. I was actually the one that asked the question about, is it better to get accreditation before starting up a clinic? So we have I work on a college campus and we have under 800 employees. And we'd like to start up a small clinic where we can do some very minimal point of care testing and like just start off really small. It's not going to be any sort of like managed care or primary care. It's more to kind of just decrease costs of urgent care and ER visits and things like that. So any initial guidance anybody has would be great. I know that's a broad question to ask, but we're starting from the ground up and I don't even really know where to begin. So that's why I was wondering if accreditation would help with guiding us or not, or if you felt it was necessary for such a small group of employees.
Go ahead, David.
From a strategy perspective, I think kind of a core question you're trying to answer is what's based on which services you want to deliver. What's the optimal way to staff that? My gut is that you can use lower level providers or even possibly a registered nurse, depending on what you want to do. Keep your costs down. You might want possibly partner with a local provider group or hospital potentially. There's pros and cons of doing that, but different ways to keep your costs down while providing the kind of access to the care that you need.
Great.
Certainly accreditation guidelines can be used in any of those kinds of settings, but I think the most important thing is the setup that to start off with. And yes, absolutely for accreditation, but clarifying what you want right now and where you might be going in the near future with the elements that David was talking about are very, very important for the process as well.
Great. Thank you. I'm a nurse practitioner and plan to start it up and run the program myself, of course, with my leadership by my side. So, yeah, thank you guys for the information, and I'm sure I'll reach out at some point for more guidance.
Well, that's what we're here for. Thanks so
Thank
much.
you.
Thanks so much. Anita Brennan, comments or questions?
Yeah, I have a question for the AAHC standards. That's that process. I understand you also accredit vendors who may be helping employers set up a clinic. Is that true?
But yes, if you take a look at the list of individuals or list of organizations that have been accredited, you'll see a number of them that operate many clinics like Premise and a variety of them. So there are a couple of different programs that AAHC has for accreditation. One of them is really focused on organizations that operate a number of different clinics. And the process involves going in and assessing the corporate offices for the corporate functions, and then spot checking various clinics to make sure that the organization is assuring that those clinics are accreditable, that they maintain the standards that we look for as surveyors. And that's a different process than an individual clinic where you go into the clinic and you look for everything there. You don't look for some parts in corporate and some parts in the clinic. You look everything within the facility. So I believe all of the ones that were listed on the slide are ones that have gone through that process. That doesn't mean that all of the organizations or the clinics that they operate are are under the umbrella, the accreditation umbrella, multi-site umbrella, you'd have to look at the listing in HHHC to see which ones are and which ones aren't.
Okay, thank you. David's got to jump off, so I'm going to quickly run around. And if anybody has a question for David, please would you identify yourself and raise your hand or put something in the Q&A. If not, what I'm going to do, I'll just go down the risk. Bohan Galiat, your thoughts? David, thanks very much. Bohan, you have a question or comment?
Yeah, I just want to ask Dr. Schultz, given the changes with virtual health and just telehealth in general under COVID, that's something that's going to be more closely looked at for future surveys with HHHCs and just helping organizations get up to standard?
Yes, absolutely. I mean, as somebody who's been working on the committees, I've been encouraging HHHC to address that, and it's on the docket. But one of the issues with them is they've had to go through a lot of changes in all of their standards to prepare them for being used within this new standards platform. They've also gone through a process where they brought in an international accrediting organization for accrediting organizations, and they have had to re-prepare their standards to meet the accreditation standards of this other element. So they've been very, very busy, but that's something that really does need to be addressed specifically, and it's on the docket, I know, for our subcommittee as well as others.
Thank
Okay,
you.
thank you.
Blythe Mansfield, any comments or questions? Blythe, take yourself off mute.
Oh, hi, sorry. No, I don't. Great presentation and very valuable information.
Okay, thank you. Brittany Chappelle, Brittany, comments or questions? Just take yourself off mute, Brittany. You'll be all right.
Sorry. No questions at this time. Thank you.
Okay. Carl Sense. Carl, you have any comments or questions?
No, nothing, Larry. Thanks.
Okay. Chad Corning. Chad, any comments or questions?
No, nothing at this time. Very helpful. Thank you.
Thank you. There's a Chelsea listed. I don't know your last name, Chelsea. Any comments or questions?
Thank you. I don't have any questions or comments right now, but thank you for your time.
Okay. David Walter. David, any comments or questions? David, you take yourself off mute. No? Okay. John Dawson. John, any comments or questions? John? All right, John, you're off now.
I do have a question for Dennis.
Mhm.
Dennis, I've heard a provider of on-site health centers say, well, we don't pay for the HHHC standard. We follow all the same rules, so that's good enough. And I'm wondering how you would respond to that.
If you can do that, great. I have yet to run into an organization that can. Things happen. All of a sudden, you're focused on something else. I swear a year has passed, and then you say, wait, did we want to be accreditable? What does that mean? Where are we in the process? And so that's the issue. Yeah, with your self-study, you do it right. You can get a lot of benefit out of going through the process. It's just so hard to keep that focus when there's not those kinds of deadlines and timelines. And for years, I was with an organization that wanted to be accreditable.
Mm-hmm.
And sometimes we started working and then sometimes we didn't. It's just really challenging unless you make that commitment.
I think that's a really good answer, because the rigor that you put the organization through goes beyond just saying, yeah, we should probably do this. You actually have to demonstrate that you do. I did have a question for David. I know he's no longer here, but I'm curious, does the clinical performance and financial performance look different for accredited organizations versus not? I don't know, Dennis, has your organization studied that or not?
Well, one of the things I was thinking of putting on one of the early slides is I wish I had an ROI for accreditation that says, if you get accredited under these chapters or this medical home, this comes out. This is what you get, but no, that data isn't there. I wish it were. And, you know, for a lot of the stuff, for a lot of the things that you do for employer-based clinics, you just don't have those hard numbers like you'd like to have. So it does come down to subjectively, do you think the process was worthwhile and of value for whatever reasons you're pursuing it? But I
Right,
mean,
thank
from my
you.
standpoint, organizations that have gone through this process and our medical homes are palpably different as you walk in than ones who have not.
Right. Thank you very much.
Thank you. Dennis, there's a question. You mentioned other accrediting organizations. Could you describe who else is out there, and do some of them focus more on on-site or near-site or mobile, and as well as is there a better approach that for AAAHC?
Well, I said that without really fully knowing. I'm so, you know, I've been decades with HHC and I have not looked at other ones. But for example, for medical home, NCQA has had a process that traditionally has been a paperwork process that I don't know exactly how it works. But in private practice, you see NCQA as a very common certifying body for medical homes. But I don't really hear about them much within the environment of worksite programs where ones that I visit. Joint Commission cert, I'm sure that they've got programs. If you're talking about specific programs like in behavioral health, CARF has got those kinds of programs. And you'd have to look around. I said that, but I'm just not real knowledgeable about them. Between a busy practice and involvement in HHC, I have not looked.
Okay, thanks very much. Okay, John Tomatis. John, any comments or questions? Take yourself off.
No, I think I'm good. Thank you very much, Larry.
Great. Kelly Wilhelm. Kelly, any comments or questions? Kelly, take yourself off mute. Okay, Tom Perky. Tom, any comments or questions? No. If not, then unless there's anyone else who would like to make a comment, I want to thank Dennis very much and AAAHC for participating in this, as well as Mercer and David Kite. If this session has been recorded and will be available for members on the NAWHC website. Thank you all very much, and hopefully you'll participate in our next program coming up relating to hospital worksite centers. Everybody stay safe and stay warm and have a good day. Bye-bye.
Thanks, Larry.